it's gonna get pumped through, it's gonna go through everything, and it's gonna get back to the pump, it's gonna pump through, it's gonna go through everything, and that's what its job is, right? That's how it works in a car. Same way in your body, it's the same way for a person. And what you're looking at is instead of looking at the pressure right outside of the pump, when it's being pumped, you're looking at it when it's like way over here, and you're just like, okay, so right here, this pump happens and it goes like that. That's what your diastolic is. So that's just what's left over in the pumps. So, and that's all blood pressure is. If you keep it like that, it makes it super easy. And so obviously, if you have too much pressure, you got problems. If you don't have enough pressure, you got problems. If your fluid gets too thick, you got problems. Diabetic ketoacidosis, you got like dehydration and all these different things thickens the blood, or you have too much, too little. There's something that thins the blood. Why do they thin the blood? Clots, things like that, right? So it all relates to pumps, pipes, and fluids. It's a lot easier to think about when you do it that way.
Just last nothing before we move on. Everything to the right there is mnemonics that we like to use. So when we're trying to get information that we're going to transfer or might be relevant before we administer any sort of medication, we look at what symptoms they're having or what signs we can see, their allergies, medications, pertinent, relevant, past history, the last thing they had, whether it was food, medication or not, what they were doing beforehand, because sometimes there could be heart attacks where something induced you to have a heart attack because you were physically moving. And then OPQRST is just like if you are feeling any sort of pain, that's how we qualify your pain, and we're able to understand how the pain is affecting you. But now let's go through our, you can ignore that. Let's go into our case scenarios. All right, emergency ambulance, EMS Station 9, respond to 157 Maple Avenue, received a call requesting assistance for breathing problems. Emergency ambulance, EMS Station 9, respond to 157 Maple Avenue, received a call requesting assistance for breathing problems.
They always say these twice.
They do not sound that clear most of the time. Sometimes you got some dude going, okay, I'm gonna start like that. I swear to God. All right, and now our patient's gonna come in. Don't mind this. This is totally part of the scenario. It's relevant. I swear. Okay. Got our patient here. Earle and I are partners. We're arriving on scene. So we're gonna go through this as if this were a real scenario.
Go ahead.
All right. EMS, may we come in?
EMS. They don't answer. Open door. Somebody call.
All right, we come in, and it is like. So, what do you do? Hey, we're EMS. How do you help me today? EMS.
I'm Earle, the paramedic. First thing when you do, I'm just gonna check your pulse. Okay, is that all right with you? Well, the reason they called is somebody was worried about you. Do you mind if I check your pulse? I don't know. I don't know who called. Is that okay with you?
Sure, I guess.
Okay, I'm just gonna feel your wrist, that's all. You can set it right there. I don't even have to do anything else.
All right. Key signs. She is responding, but seems a little confused. She's not looking too hot, and obviously she doesn't want us here. But we're gonna continue to assess. There is a friend on scene. Said that she wasn't feeling well earlier and that she got worse, so she called us. So Earle just took her vital signs, and this is what it looks like. Now, who can look at this and who can look at that and tell me what's something that we're going to notice that's different?
What's some of the things y'all see?
Heart rate is elevated.
Heart rate's a little high, right? That's a pump. That's a pump thing, right? It's pumping too fast. What else do y'all see? Yeah. Blood pressure is low, exactly. So that's gonna be a fluid problem, a pump problem, or a pipe problem. We're not sure yet. We gotta work through that and figure out what's causing that.
You're not like getting rid of like CO2.
Yep. So typical, I don't do percentages. I mean, I know that it's 5 to 6% is what you're supposed to see where it says 3.8 right there. That would mean that she is not getting enough CO2 out, because you would want that number higher. If your body's compensating and you got something going on, that number would be higher because blowing it out more. If you're not blowing out enough to that 35 to 45, it means you're holding on to it for some reason, right? Or you're hyperventilating. So it's one of those two things. You just don't have enough to get out. All right, anything else? Anybody see anything else? So we're getting to the 92, right? We're getting to the 92.
Not too bad, but not great.
Yeah, not great. It's definitely with everything else, that's a number that I'm keeping my eyes.
Their respiratory is like a little higher than that.
Exactly.
Yep, she's breathing a little more, right? This over here is a vital sign. We just couldn't put it on here. So we take her sugar levels and it says high blood sugar. That's it. We don't get a number. It just says high, done.
Most monitors cap out at 300. So if it's above 300, it's gonna say high. What's the normal range? 80 to 120. So she's got a lot of sugar in her blood. So we're thinking, I might got a diabetic here. So now we're gonna go back to our patient now that we see these vital signs. First thing we're gonna do. Hey, are you diabetic by chance?
No,
No. Do you take it? So you take any medications?
You talking to a friend, hey, you know, just diabetic, you know what's going on?
Yeah. So he's gonna be talking to the co-parent friend who
Yeah.
knows what's going on if
Why
she's
do you know
there.
what's going on? She normally like those type of things.
Got any insulin? You got any, you take your insulin today? You eating food?
a snack.
You have a snack?
I'm feeling too good. No upset stomach.
Yeah. I bet you're really thirsty.
Yeah,
Yeah.
my mouth's dry, lips are chapped. Feels weird.
You feel weird.
Yeah.
Yeah, okay. Well, we're gonna take you in the ambulance. So we're gonna pull you up, get you on the stretcher and take you on.
Ambulance.
Yeah, so at this point, this is when I'd say like, okay, so here's what I think. A lot of times I do this, but I stay away so they can't kick me in the face. I learned that twice. So I said, I was like, okay, so here's what we're thinking. You know, you're diabetic, right? Okay, so you're diabetic. Everything that we're seeing shows that you have way too much sugar in your blood. Your insulin, whatever it is working, your sugar spiked. Talk to someone who's diabetic, they know what you're talking about. Your sugar spiked, it's starting to have an effect on your body, it's starting to have an effect on your vital signs. I'm worried about that. I'm worried about you right now, and I think that we should get you to the hospital. Would you come with me, or at least get to the back and let us check you out? Is that okay? All right, sure, cool. And then you step back, you always take a step back, because sometimes when people are confused, they do weird stuff. So we get her in the back, she's coming with us, things are good, we're like, okay, we're gonna go do this, we're gonna make this happen.
So, things to take note. When we get her on the truck, we figure out this information, like what her name is, how old she is, we're always keeping track of that. So this is Maria, say hi to Maria. She's 29 years old. Do you know she's not fully there? Yeah, question.
What would happen if a patient just says like they don't want to cope with their vital signs are like really bad?
Great question.
Yeah, it depends on if, there's that implied consent, if they can't make decisions for themselves. In the state of North Carolina, if somebody doesn't seem like they're fully there, or they can't fully take care of themselves because something's affecting them, that like they don't even really know what's going on. Or they can't even tell you that they're living right now. They're looking at their hands and they're going, what kind of tree is on me right now? We're like, okay, bro. So that's if they're bottoming out, they're dying. But we have the implied consent, then we take them. But if they're fully aware of what's going on, and they're just, it looks like they're going down a bad route, they can usually deny the request, and they have to sign a form. But legally, we cannot do more if they do not want us to take them.
We have very specific criteria. So A&O is alert and oriented. So we do alert and oriented. I'll say 5 questions. I'm like, hey, what's today's date? Okay, and who's the president of the United States? And this is a hit or miss because some people don't know, honestly. Like, so, but you just see it. If they get it right, you're like, cool. And if not, you're like, no, I'll give you one more. Joe Biden. Okay. All right. So you have so February 22nd, Joe Biden. If I give you a quarter, a nickel, and a dime, how much change do you have? Quarter, nickel, dime. 24 cents. All right. So far, alert and oriented times 2 out of 3, right? Okay. So I say, okay, what year is it? Okay, cool. So she's got 3 out of 4, so she'd be alert and oriented times 3, right? So that says that there's a little bit of a deficit. She's a little bit confused right now. So what I would do is I would take that evaluation, I would take my vital signs, I would take everything that I've gathered, talking to her friend, everything, and I would get on the phone with medical control. And I'd say, listen, here's the deal. This is what I have. This is what her mentation is. This is what her status is. This is what we're seeing. She says she's not going, she says she's not going. She doesn't want to go. Now, if she's saying like, I'm not going, pink elephants, whatever, then you have a little bit more of a fighting stance. But if it's just, she got 1 or 2 questions wrong, but she's still, she knows her name, knows her date of birth, knows her social security number, knows where she's at, knows her home address. Then it's like, you call medical control, you say, listen, this is what I have. This is what I'm going to do. This is what I want to do. But what do you think? And then you put it on the doctor, honestly. You say, this is what we have. This is what we're going to do. Because the doctor in the state of North Carolina says, I will take responsibility, get them here now. And at that point, it's soft restraints. There's, chemical sedation. If you're gonna have to chemically sedate, you're gonna talk to the doctor about that first. You're gonna get approval over the phone, it's on the court lines. So that's kind of how that progression works. But we have certain things that we have to go through. And like GCS is one of those things. GSS is 14. Why is it a 14? What's off? Is it confusion? Is it a mentation thing? That's one thing, but that's the protocols that we have to go through to get that done and call medical control and ask them.
Earlier, we noticed, or front row noticed, she's got a fruity, like, sort of alcohol-like odor on her breath. But it doesn't look like she's drinking. Her friend doesn't say she's an alcoholic. And she's breathing, pretty fast, trying to get all that CO2 off. And, her heart rate's a little fast, and she's got that bad blood pressure. So, what are we gonna do? What we're gonna do is that she's probably experiencing she's probably experiencing ketoacidosis. She's type 1 diabetic. Ketoacidosis is essentially the body can't metabolize, or something has caused it, like she's sick. And because she's sick, her body's not working as efficiently as she could. She's probably used up all her insulin, and then she's got all this sugar that's going unprocessed. And so then she gets the fruity odor on her breath, and it starts to affect a lot of things like her function. And when you get more sugar buildup, your blood kind of gets like thick.
Like syrup.
Yeah, syrupy.
And the reason that it's fruity smell is because like they call it ketoacidosis, because your body stops using sugar as a source of energy, right? She's diabetic. Insulin and sugar need each other. Insulin is what takes sugar and it allows it to like process and put it out for energy through the cells. When that combination isn't happening, sugar's just rapidly flowing through the body, and it keeps building up and building up and building up, and that's how it works. Blood gets thicker, cells aren't getting fed, it needs something, so then it moves to your fats. Once it goes to the fat, it starts breaking down, and without going through a whole pathway, essentially what happens is it breaks down, releases these metabolites, which are called ketones. Ketones get blown out, and they're sweet smelling. So when they get to a certain level and you walk in and you're smelling that, you ever have a friend who's diabetic or anything and you start smelling that? All right away, it's bad.
Yeah.
This is related. I had a buddy who figured out his girlfriend was diabetic. Neither of them knew because her pee was really sweet. No further questions on that one.
That's actually,
Oh, okay.
that's actually how doctors used to diagnose it. They
Yeah.
would taste urine.
Mhm.
And if it was sweet, then it was meant you were spilling the glucose out in your urine. And it's I always described it like insulin is a key that tells your cells to like open a window to get the not exactly a door, because they're kind of insulin helps get sugar into the cells. So someone who's has type 1 diabetes, their body's not making the insulin, and so they have to inject it. And if they haven't taken an injection, then their cells have no keys to open windows to let sugar in. So the cells, even though they have a lot of sugar in their blood, their cells are starving. They can't get it.
Cool. So we're gonna try to take her and go, because she's having a medical emergency. So this is where the paramedic comes in, because this is out of my scope. I can't really do much besides put her on oxygen, because her SpO2 is a little low. So there's different types of routes in giving oxygen. The one that I would give her is called a nasal cannula. It's the ones that you see where it goes, it got 2 little like small spikes. They're not really like spiky, but that's just how I visualize them.
They go up your nose and then it goes around, goes behind your ears, and then it's connected to an oxygen canister and it gives you a flow of oxygen right there, right in your face. You're breathing it in. Hopefully that's gonna bring her SpO2 levels up, so her blood oxygen levels up. And then this is where I pass everything to Earl, because I can't do it. So,
Cool, so, I'm gonna get into the back. First thing I'm gonna do is I'm gonna start line on her. She needs fluids, right? We need to dilute that, we need to dilute that blood. That blood is thick, that blood has too much oxygen, it has too much, not enough oxygen, it's got too much glucose. So it is being filled up with all this other stuff that is not what it needs to be. So we already got some oxygen on board. Oxygen is gonna bind to hemoglobin. But once it gets thick, blood needs its, like visceral nature, right? So it needs to be somewhat thick, but watery. It needs to go at 70% water. Her blood's too thick. I'm gonna start the line, I'm gonna start a big line. And then I'm gonna start giving her fluids. Number one thing that everybody does for DKA, there's not much, we can't give insulin in the back of the truck. We don't have it, they don't offer it. That's not something that we do. It's out of our scope. But what I can do is I can give her fluids, I can give her oxygen. When things start changing, I can start doing more. If her blood pressure does not come up, if I am pumping fluids into her, and now I'm worried, like, listen, she's got a liter and a half of fluids in her. Her pressure's not coming up. That's when I'm like, okay, now I have some things that I can do, because I can start giving her things that are going to squeeze. It's gonna make those pipes smaller, which is gonna increase pressure, which is gonna increase blood pressure, which is gonna increase perfusion, right? So, those are gonna be like vasoconstrictors, and those are things that we can do too. But with her, hopefully, we give her fluids, everything's good. So, high flow diesel, that's another thing.
everyone thank Maria. Let's go ahead and do a 5-minute break because it's hot in here. And I don't want you guys getting dehydrated. So snacks, 5 minutes, come back, we'll get started on the next patient.
University High, call for a headache. Emergency ambulance EMS station 9, respond to University Heights, received a call for a headache. All right. When you get on scene. Oh, okay, that's great. Okay. Well, that's fine. So there is a 20-year-old man there, he's walking around, talking. He seems like he's taking up a lot of space in the room, so we're gonna go over and we're gonna talk to him. All right, EMS, how you doing today? Good. You got a headache? You just chilling?
Is this another one with green cold?
Yeah.
What's going on?
Friend says that they were playing football. Buddy here got tackled. He hit his head and then he went out, he was knocked out for like a minute or so. And then he gets up back up and he's fine. He's chilling, he's like, what's up, bro? And then, yeah, you see, he's like, you were out, bro. And so they get back to the car and then this dude's just like, he's like, okay, well, where's my mom? Where's my mom? And then, they get back to the house and dude's like, okay, don't touch me. I gotta go to the gym. Like, stop trying to get me to stay. I need to go to the gym. So we're here. And, originally they said that, in the car, he's like, yeah, my head hurts. I got a headache. So that's what. All right. How you feeling right now? You feeling okay? All right. You mind if we look at your head? You mind if we take some vital signs? Why? We just want to check on you, see how you're doing.
So you have a headache, right?
I'm fine.
You're fine?
You're fine. Yeah. Your buddies here are really worried about you. We just want to check on you. Is that okay? Yeah.
Tell me what happened with the tackle. What happened?
I was just playing football.
You're playing football? They said you got knocked out. Did you get knocked out? You don't know? You don't remember? Do you remember the hit roll?
No.
Okay. Do you remember what you did this morning?
I went to the gym.
You went to the gym this morning?
Yeah. Trying to get back there.
Trying to get back to the gym
Yeah.
again?
Yeah.
Oh, you were a two-a-day type of person, huh?
Yeah.
Okay, no problem. Well, let's see, if we can get some vitals on you and everything, then maybe we can get you cleared up, we can get this taken care of. For instance, you had a headache, they're worried about you, I just wanna make sure you're good, is that cool with you?
Yes.
All right, awesome, I'm gonna just check a few things, right, like blood pressure and stuff like that.
Is this gonna take long?
It shouldn't, I mean, yeah, it's just, if you just let us kind of get what we need to get done, we'll be out of here for sure.
So we took a bite. Let's compare. What's different? Really bad blood pressure. Yeah. 168/84. Woo. Dang. What else?
Two is not a number.
Oh, we didn't take it. He's moving around a lot, he's talking a lot. Oh, one more, or two more things? Employee rate is on the lower part of the package. Yeah, he's on the lower side. One more thing.
I'll give you a hint. This person is someone who works out once or twice a day, plays football, in shape, younger person. You think they should be at 94%? Right? Yeah, like when you get, it's all totality, so you're looking at your patient, and you're seeing, okay, this doesn't jive, like, why are they not, why don't I have a better one? So at that point, I'd be like looking, I'd be doing cap refill, I'd be seeing, okay, are you perfusing? You know, is it coming back? If it goes white and comes back pink in less than 2 seconds, we're in good shape. If not, what's going on? Another thing I'm gonna be doing is I'm gonna be doing a full look over. And this is just, especially while she is talking, I'm gonna be standing and I'm gonna be watching. I'm gonna get the information I need. I'm gonna watch mannerisms. People do weird stuff when things start going on, right?
So, one thing to notice, we're checking the head, or at least Earl's been over there while I'm talking to him. And so one thing you notice is that he's got a blown pupil right here. Like, and when I mean blown, I mean like, crack, that thing's gone, splat. This other eye's looking cool, but this one's like all sorts of messed up. This is an interesting fact, and those of you who have taken, I think neuroscience 1, you learned this in your intro to neuroscience class. When you've got a blown pupil in one eye, that usually means the other half of your brain is affected. So it's the opposite. And your oculomotor nerve is about right, say like right here, more leaning on the left side. So that probably means he got struck right along here on the head. And when Earl's looking over at him, he can see he's got like some weird stuff going on. He's got like a full head of hair, so it's kind of hard to tell. But once you look at the pupil and you start looking at that region, you're like, okay, someone looks a little swollen, someone looks a little funky.
Yeah, one of the things I do is I'd say like, hey, you mind if I feel where you got hit? You know, and I try to feel and palpate. You know, how about your head hurt? Scale of 1 to 10. This is when we start doing the PRS. All right, you guys pain in your head? Yeah, okay. Scale of 1 to 10. How bad does it hurt? Number 1 is nothing. No, not a big deal. 10 is the worst pain you've ever felt in your life. All your bones breaking in your body while you're giving that. How bad is it? You know, and from that, we decide, okay, you know, oh, I'm at a 4. You're at a 4. Okay, so 4 is not high, right? But to be concerned afterwards. So we're a couple hours after. You'll see if I see anything. You'll feel soft spots. You'll get to a point where they may be like, yeah, that's sore. You hit one spot and they go, ugh. And when they start moving away from you, that usually means, especially on the head, something was chipped, something was cracked, something's going on. But when they get a soft spot like that, it's usually not good. They need to get a scan.
Second thing, you got some sort of damage to your brain, like a traumatic brain injury. One thing about his blood pressure, we opened that and we were like, whoo, 168, dang. That's probably because it's trying to make up for the increased intracranial pressure. So your blood's trying to keep up and make sure that everything's staying where it needs to be to keep the fact that you've got some injury here and now your pressure balance is totally off. Something's not right. Also, this dude, if he is getting upset, that increases anxiety, which, you know, for all the psych students, when you start to get, you know, a little like, I ain't gonna do all that, your heart rate's gonna go up and your blood pressure is gonna go up too. All right, so this is Todd Martin, 20 years old, no. So when we talk to him, he is like, I don't know what's going on, I don't really want to do all that. And when we try to take him onto the truck, he starts to get a little aggressive. So once we see, you know, he's got some real bad brain injury here, we want to get it going. And he's not in the state right now, according to his friend, the way we're talking to him, this might be implied consent as well. So we're talking to Todd, it's like, hey, we noticed, you know, we're really worried about you. We think you should come with us. We think we should check you out in the ambulance. Is that okay? No. No. Do you mind if we just go though? You're like, we should check you in the back. We just want to see.
I'm really good. I'm good.
You're good. And then this is when we're like, well, we really think you should go. And Ty just starts like throwing his arms at you. He's like, back off, bro. Like, I ain't trying to do all that. And like, if you're close enough, he will hit you.
He's upset right now. He's mad. So,
I'm on the phone with the medical control. I'm like, yeah, we're gonna have to give somebody something.
so,
We're gonna give some medication on this one, because it's young, athletic, strong. Fighting is gonna get you hurt and get them hurt, especially if you think they have a head injury, it's only gonna make.
I'm gonna ask, if someone's in a situation like this, where there's someone who's really doesn't want to go and trying to fight you. In this particular instance, would enlisting the help of their friends to get them on the ambulance, is that a liability, or are you allowed to be like, hey guys?
No, absolutely. If you can get them, if a friend can get them to say like, yeah, man, I wanna go, that'd be fine. Yeah, fine, why not? Why not? 100% is perfect. We do it with families all the time. Son calls for mom doesn't want to go, mom's, 75 years old, she's had chest pain for 2 days, she looks like death on a cracker, and, that's it. Like, there's nothing that you can do. And if she says no, but you start getting the family, hey, call the grandkids, get them on the phone, whatever we can do. If we know that they need to go, and I'm looking at something, I said, you have to go. This is going to be bad. Like, I'm gonna be back here in 2 hours working cardiac arrest. If you don't come with me now, then we'll do anything and everything that we can. There's no liability to that whatsoever, because essentially it's gonna be their decision. Now, if they're altered, then it's no longer their decision. I call medical control, put that on the doctor, but they're still alert and oriented ×4, right? Remember ×4, everything. So event, place, time, person. If they're still alert and oriented by that, nothing you can do. I've done that where I've just pulled outside of a neighborhood and waited for the call and got the cardiac arrest call.
Use face recognition.
So,
all right, so thankfully, I got my ALS here, my paramedic. We really need to get Ty on backboard, secure his spine. Because we've got a traumatic brain injury, who knows what happened to him when he got knocked out, we might have some issues there. Also, we really don't want him to thrashing his head around when he's getting mad. He's like, stop, I need to go lift my weights, like, he's ruining my groove. So, I'm gonna be like, yo, Earl,
yeah, so I got to go ahead. I'm probably gonna go ahead and get something up. It's gonna be like intravenous. I'd probably clarify with the doctor, because if I think they got a blown pupil, they're gonna have a brain bleed. The last thing I want to do is introduce something that's gonna cause cross the blood-brain barrier and be necrotic or cause any issues with the tissue that are there. So I'm gonna verify that whatever I give them is gonna be. I don't think Haldol really does that. Versed, I don't believe he's gonna cross that. But that's something that I would verify and make sure.
so we're gonna try to get him to stop thrashing around, get him stabilized. His oxygen is low, so we're also gonna do another nasal cannula because he's only on 92. Most of the time, if he's thrashing around, that's the easiest thing to pop on. He's not gonna like flap at it, even though we're trying to put him on a backboard in the process. That might be the thing to do. We're gonna rapid transport because he's got a traumatic brain injury, and that is just a big no-no. Like Earl said, he can go to cardiac arrest. He could become permanently brain damaged, so vegetative state. We want to make sure that he gets to the hospital right away.
Actually, there's studies that talk about hyperventilation. So typically in the brain, like hyperventilation, not good. But once you start seeing herniation of the brain, meaning there's so much pressure, brain starts getting shifted and pushed. Hyperventilation may help because now you're constricting all of these blood vessels, and depending on where the bleed is, when you hyperventilate somebody with oxygen, it's going to cause vasoconstriction, and it's going to cause cerebral vasoconstriction as well. So there's a fine line as to when to do it and when not to do it. But sometimes hyperventilation is going to help save as much brain as possible, even though you know they're going to lose something. It just depends on what the situation is. That's kind of like fire straits.
I think there was a study, I may be corrected, but it's like a majority of like high school students who play football end up with a concussion, and it's not recognized until years later on, until they're more aggressive, they're not really themselves, and professional football players too, they go from one second being this guy who just loves to play ball, loves his family, next thing you know, he's hitting his wife, and he's unhappy, and all these weird psych aspects that you want to look into after people have received concussions or some sort of brain injury that's gone on for years. Thanks, Ty. We're just being a little faster than I thought I would, but that's fine because this is the hands-on section. So if anyone have any questions? Yeah.
How do you induce hyperventilation?
Hmm?
How do you induce, how do you make someone hyperventilate?
Back valve mask.
So there's like a mask, and then attached to it is this bag of air, and that's the pressure, kind of like if it was their lungs. And then we're squeezing it, and that's gonna induce them to use the same way.
You guys will see it on movies, TV shows, and everything else, where they're just like, oh yeah, just like nonchalantly making someone breathe like 48 times a
But
minute.
they're squeezing the
You know,
bag so tight,
yeah.
you don't want to squeeze the bag because it's like so long. Well, like Grey's Anatomy, you see them, it's like
Yeah.
partially like low pressure bag and they're squeezing that thing and you're like, oh, I don't want to be that guy.
I told her, I said, my like the job, like my dream EMS job of all time would be just have like movies and TV shows call me and be like, hey, does this look like absolutely stupid? Because there's so many things I can't watch. Like, oh, yeah, I mean, like, literally, like, IVs are going the opposite direction. They're like tapping the spine and being like, oh, they're in VFib, asystole, like just throwing out words they've heard from somewhere, like, none of it makes any sense. Like, somebody should I can't watch. It's dumb. So I would love that to be my job, like, my job, that'd be awesome. Pay me $150,000 a year, let me do that. Huh?
Any other questions? Sweet, all right.
And another call, and they come like this. We just got finished with that one, you're toned out from the hospital. Awesome.
Okay, emergency ambulance EMS station 9 respond to assisted living home. Received a call for a fall. Emergency EMS station 9 respond to assisted living home. Received a call for a fall. All right, please go to the next slide. So, we get on a call, and we don't have a patient active for this one, but there's a few more. When we get there, he's laying on the floor, kind of like, you know, something like that. And he's unresponsive. An older guy, he's like in his 70s or 80s, you know, he looks a little frail, looks like maybe he just fell, hit his head, and we're like, ah, man, so he didn't hit his head. When we get there, his breathing is shallow, he's not breathing super well, he's pale, and he's blaming. So, if you're interested, you don't have to. If you would like to, come grab a stethoscope and a blood pressure cuff. It's going to teach you how you take blood pressure and how you listen to breath sounds. So, if you would like to, come on up. And if you want to switch up, like grab a partner, so you're switching on, or you're practicing on each other, go for it. Sure.
Yeah.
Let's switch. You want to go up?
That's a good way to do it. And one of the things we're gonna talk about too, is these things right here. I can't tell you how many calls I've been on where somebody's like, yeah, my pressure is 270 over 150. And they're using this thing and it's like, yeah, I really need to throw it away. Like, I don't think it's working anymore, you know?
I did do this though, so that you can see what it looks like from someone taking your blood pressure, so you can go and see how it works. Go for it.
Check it out.
Pass it around.
And what we can do too, is like, we can do one of these and we can do a manual and see how it goes.
Yeah, we could show, we can prove that these are
If
inaccurate.
anybody wants it, it's up to you. And it's on. Wait. All right, so. A little different there, but- Hands on, we are hands-on folk. So, when you're putting these on, one of the things that you want to do is first, you need to make sure that you're able to get to them, right? One of the things I like to do is hook it onto a shirt, I hook it onto a collar, I hook it onto something. If I'm gonna be using that hands, put it where I can see it, right? So, makes it so much easier. Number two, this artery. You want it, you have a brachial artery that runs right here. Sometimes it's hard for people to feel, but if you push up right into that bone and kind of rotate just under that bicep muscle, more toward the back, you're gonna feel a pulse. That's a brachial artery. This is actually the number one spot we put in pediatrics. So much easier to do, radial, you know. Anyways, that's what we did. So you want this where it says artery. If you look on these, there's always like a little line, right? It says range, and then there's like a dark dashed line. You want it right here, right on that artery. That's gonna give you the most accurate. Doesn't have to be, but it's just a great way to start practicing to get lined up right exactly where you need. So y'all get them on? Point them. You take mine.
Whatever you want to do.
All right. Once y'all get that on, you're gonna have to turn it to one side so that the chamber is relaxed, right? So that you can pump it up and it actually fills air into the balloon. Essentially, the way these work is it's going to squeeze and squeeze and squeeze until it shuts off the blood flow. Just enough to where it doesn't register anymore.
Use your dominant.
Oh, yeah.
So first, this valve, you should be able to control it just with a finger and a thumb. Don't crank on it, because you don't want it too tight, just tight enough to hold it. My right hand, my right hand's dominant, so my left hand can just do whatever, you know, I can hold things, but I need to be able to control with this hand, and then you just make it righty.
Yeah, you like push it away from you.
Yeah, so it's actually opposite, it's lefty, it's normally righty, tighty, lefty, loosey, but this is, y'all figure it out.
Yep.
And then start doing it. But when you wanna release it, just try to roll your finger like you're barely putting any pressure, because it's easy to release it and have it all, it's not really fixed.
Mhm.
That control is.
You gotta release it slow, because I'm gonna teach you what it means when it bumps. As you go down, if you release it slow, you're gonna see the thing bump.
So if you're taking the blood pressure, you're gonna grab it, set the scope. I'm gonna put it on. Once you put that on, you're gonna take your set. Why do this? I got a little thing.
So as that brachial comes through right here, brachial's gonna come down, it's gonna come through your arm and it crosses over. Brachial, just think of it in terms of like, it comes over here, it crosses over, and eventually turns into the radial, right? It's not exactly how it works, but it's a good way to think about that as it crosses over. So when you're on your elbow, you're gonna wanna do it right above the elbow. I take my 3 fingers and I put them at the back of the elbow, and I push up. That's gonna keep the elbow locked in place, and it's gonna do a nice, good job of being able to open that space. So from there, what you're gonna wanna do is you're gonna put it on this side so they can see. You're gonna put that right here. It's like right off, you're gonna feel that little like, kind of like that bulging area that's right here, and as it goes in, you're gonna feel that little soft note. That's exactly where you're gonna put it. And when you have it, if I have her arm like this, I have control of that, right? So now try to bend your elbow. Like all I have to do is just put pressure down here, so if they're moving around and doing that, once I get it here and I'm holding that, if we're moving around or whatever, I have control of that, I know it's in the right spot, and I can listen. Then all I have to do is just wait and listen for it. That's an easy way to keep it controlled. I'm gonna go around and make sure that they've got the things off, because I'm seeing people like, rip them off, rip them off, rip them off, put them on.
Yeah, no, I'm having a.
So I'll show you what's up. All right, so right here.
You want to talk her up? Sure. Let's see, Mike.
Thank you.
Oh, okay. Actually, you can slow it. Keep like the other side.
There's an extra stethoscope here.
I can try.
This is mine.
So to feel the ball.
I don't think that, you know, earwax is actually antibacterial.
Why not?
No, I don't.
Oh, that's for the. Elbow and, I think we have it on there.
I'm gonna have it straight over here.